Second panel, Health Literacy Policy and Programs is the title of the panel. We'll be describing examples of health literacy policy and programs. Again, I'll introduce all of the speakers first. As they do their presentations, I'll ask you to hold your questions until they've finished. Lila, who's sitting down here in the front, has these signs. We'll remind you where you are if you lose track. And we'll try to keep on track. Our first speaker on this panel is Dr. Sandra Vamos. Have I got that correct? Okay. Who is Senior Advisor on Health Education and Health Literacy for the Center for Chronic Disease Prevention and Control at the Public Health Agency of Canada. She provides strategic agency direction and contributes to the development and implementation of frameworks, approaches, tools, and products to build internal and external capacity for building health literacy awareness and the application of concepts into public health practices and programs. Prior to joining the Public Health Agency, Dr. Vamos was an Associate Professor of Health Education and Graduate Coordinator at the Simon Fraser University in Vancouver, British Columbia. Her experience includes health promoting schools, health literacy, curriculum development, and teacher preparation. Higher education work focused on both the creation and restructuring of university-level health education program and improvements in school health education K through 12 to enhance health literacy through curricular and programmatic innovations, emphasizing partnerships including families, schools, communities, local, state, provincial, national, and international organizations, associations, and institutions. So we're looking forward to her comments. Dr. Nicola Dunbar will follow her, is a program manager at the Australian Commission on Safety and Quality in Healthcare, with responsibility for a range of program areas, including the deteriorating patient primary health care and patient-centered health care, including that aspect of healthcare in Australia. She has a background in health research, program management, and policy development, and has worked for government, universities, and non-governmental organizations in local, state, and national levels. She has an advanced degree, a Ph.D. in neuropsychology and HIV infection, and a master's in policy. Third on the panel will be Dr. Frederia Gazzotti. Following her degree in Oriental languages, completed her doctorate in sociology with an emphasis on communication. She joined the local health authority of, forgive me for the pronunciation, Reggio, Emilia, Italy in 1998, focusing on public health communication. She is responsible for the communication staff activities, which include front office and citizen welcome, public relations, press releases, web communication management, both internal and public website, and conference training organization. She coordinates health literacy panel for the region and stimulates and overviews health literacy projects in all the local health units in the region. And then we have also, to conclude this panel, Dr. Jennifer Lynch is the project coordinator at the National Adult Literacy Agency in Ireland and is responsible for the health literacy project initiatives there. She joined that organization in 1997 as their first communications officer. She holds a diploma in plain English and was responsible for introducing plain English to the agency and other governmental agencies. She has been responsible for commissioning and managing information technology projects, such as a website, healthliteracytools.ie. She has a master's degree in sociology and a postgraduate diploma in public relations. So, welcome to the panel. Dr. Vamos, you are up first.
Well, thank you for today's invitation. I'm very pleased to be here. And I'll provide a brief snapshot of health literacy in Canada, which is going to include just a very brief context, a few key milestones, some key recent developments of health literacy activities nationally, provincially, and territorially, and an introduction to a recent discussion paper, which is a framework for action, a health literacy intersectoral approach. And also that leads us to where we're currently at and where we're going to be heading. And for those of you who aren't aware, the Public Health Agency of Canada is the Government of Canada's main public health agency, and it's responsible for public health in Canada. And I guess it could be seen as an equivalent to the Centers for Disease Control in the U.S. And over the past couple of years, the Public Health Agency of Canada, or FAC, which I'll be referring it to as, has been linking and aligning health literacy work with agency, branch, and center public health objectives. And many Canadians have low levels of health literacy. Approximately 60% of Canadians and 88% of seniors have low levels. And research also indicates that certain segments of the Canadian society exhibit disproportionately lower levels of health literacy, such as older adults, the Aboriginal population, recent immigrants, those with lower levels of education, socioeconomic status, and low English and French proficiency. So to improve health literacy, we know that we need to improve the knowledge and skills of those, obviously, that receive the health information programs and services, and obviously those who provide those things as well. And while there are many definitions that exist internationally, this is the definition from the Canadian Expert Panel on Health Literacy, and it's the one that's most commonly used and cited in Canada. And this definition implies that health literacy is an interaction between individuals, systems, and in the settings that they're in. And it also takes a look at and implies that health literacy is a shared responsibility across the life course. And that's something that's unique in this definition, and it's not necessarily seen in all of the other definitions that are out there. And while internationally health literacy has gained momentum in research, policy, and practice, health literacy is still a relatively new concept in the country. This is just a brief snapshot of the Canadian context. And there's a growing recognition of the important role that health literacy plays in public health initiatives. And efforts are anchored in health promotion and not necessarily driven by the medical system. And as an emerging field, there are many pockets of health literacy initiatives that exist, and you'll see that in some of the slides. And it's not a part of a larger national approach, and much of the efforts are exhibited by and done by academics in the non-government sector. And policies related to health literacy are at a very early stage, unlike some other countries. And there's stronger research that has been evolving as well throughout the country. And there's been some interesting work done with the Internet Adult Literacy Survey. And this has been seen by and done by the Canadian Council on Learning, which is a large national organization, but it has just been dissolved last year, and they've done conducted an in-depth analysis of the IELTS, and also some academics have still been using the IELTS as well, and some recent work has been done with the IELTS with older adults. Here are some milestones in the Canadian path to health literacy. Really began in the 1980s, starting with the provincial organization, the Ontario Public Health Organization. And really, they took a look at their interest in literacy in health. And then this led to interest with the Canadian Public Health Association, and they were involved with a couple of national health organizations. And delegates at this particular event, they suggested that there should be an expert panel or a committee. And so delegates were put together, and they released a milestone report called A Vision for a Health Literate Canada. And they recommended a pan-Canadian strategy for health literacy. And they also called for policies, programs, and research to increase the low levels of health literacy and to reduce the disparities in health. And building on that work, then a discussion paper was released, and this was called the Intersectoral Approach to Improve Health Literacy for Papers. And input was reflective from think tank participants. And think tanks, the think tank participants were policymakers and academics, researchers, health literacy experts. And this discussion paper I'll talk about at the end of the presentation. And really it was just to further the health literacy agenda, and it called for intersectoral collaboration to really move things forward due to all of the keen interest, momentum, and activity that was going on. And it's posted online by another provincial association, the Public Health Association of BC, and really Dr. Irv Rootman and Wayne Middick out in Vancouver took the lead on this. So with the Canadian initiatives, there's a lot of developments that have been happening outside of the government, but more recently, the last couple of years, FAC has been participating and have been quite active. I'm going to highlight on separate slides 3 recent FAC sponsored initiatives where a lot of different people, partners, and organizations have been involved. But I would first of all like just to mention that outside of the government, the Canadian Medical Association had passed in August 2010 2 resolutions to promote health literacy. The first one urged governments to develop a national strategy to promote the health literacy of Canadians, and the second one dealt with clinical practice and raising awareness among physicians. And the response to the second one was the development of an online module for physicians and nurses, which I will also touch upon in a second. There's been a lot of activity as well with national organizations and health alliances, and they've been dedicating their national tracks and conference themes to health literacy, such as organ groups, such as CEDAPAC, the Chronic Disease Prevention Alliance of Canada, which has been new. So that was something that has been happening as well. Also, there's been activity flourishing in school health literacy, whether it's been in developing measures for school health literacy or developing national tools for school improvement. So with the modules, there's one targeting public servants, which is a FAC module, which is to be launched in French and English in January 2013, and the Canadian Medical Association working with the Canadian Nurses Association, and this provides, which is going to be launched in the, I think next month. The English has already been up, and this is accredited medical education for those particular groups. Just very quickly, there's been a health literacy scan project conducted by the University of British Columbia, and it really took a look at a FAC-sponsored project, taking a look at noteworthy health literacy activities, and it was really 3 scans. An internal scan taking a look at federal government initiatives and federal employees who are engaged in health literacy work. The second one was an external scan, taking a look at what's happening with Canadian activities outside of the government, and a third international scan of what's happening, comparable large-scale activities outside of Canada. And really, the findings took a look at, in terms of the most prevalent type of things happening, described by key informants, and it really was knowledge development and translation work, but for the purposes of capacity building and awareness raising. So there's been a lot of development of educational resources in working with vulnerable groups such as Aboriginals and seniors. And when asked in terms of infrastructure building, it's really in its beginning stages. And there are, even though there's some champions, the key informants mentioned that infrastructure is in its infancy stages, and there is a need for further funding, and there is a need for positions to actually do some of this work. The second example that I wanted to share is a Canadian health literacy from the Fields project. And the purpose of this project was to gather a range of peer-nominated positive health literacy in practice projects using the consistent Canadian definition to really show what health literacy looks like to share with others. And 3 to 5 page case vignettes were written up by individuals and groups with these particular projects to share and consolidate with an online resource to share with others. And there are 33 across the provinces and territories and regions. And really, it focused on different topics from oral health to mental health. And it really showed what was happening in different settings, from schools to workplaces. And it captured different issues and priority populations, from Aboriginals to schools, to children and youth and families. And hopefully it's going to help raise awareness, and also shows pockets where work needs to be done. In the third example, very quickly, it shows an approach to integrate health literacy components into existing work with 3 different locations and 3 different vulnerable groups. And it works with seniors, rural families, and also immigrant groups in 3 different projects. But the idea was to build capacity with staff. And a key finding was that a lot of different groups needed a lot of learning resources and time to actually become health literate. So it was all about organizational change. And this was an 18-month project. So to end off, this is the intersectoral approach, which really is a framework for action, and it's an umbrella document. And what it consists of are 3 components on the left, and the 3 components really identifies a strategy that's deemed essential to move forward. And there's a list of objectives for each of the 3 components on the left, and each of them have sample activities, not too dissimilar from the U.S. National Action Plan, but for the Canadian context. And there's 5 different partners or sectors that also are necessary and interrelated to actually move the agenda forward. And they're categorized in a joint effort, and what groups and individuals and organizations are invited to do is to take a look at what they're doing and put the ideas, their own ideas, in this context and make recommendations on how this could be used and any other ideas to make changes. And this is considered an important step to actually move in the right direction. So it's posted on the Public Health Agency of BC's website, and there are definitely examples of potential which we still need to do, and there's areas of successes based on the Health Literacy Scan project that I mentioned, and there's examples that from the Scan project and different models, and there's different resources, and there's potential partners that we hope to hook up with to move in the right direction and moving forward. So if you have any other questions, I know there's a lot to fit in 15 minutes. My contact information is on the slides, and there's resources here if you'd like to access the documents. Thank you very much.
Okay, thanks very much for having me here. I feel really pleased to be able to come, and thanks to the IOM for the invitation. I'm going to take a bit of a different approach in what I'm going to talk about. I come from a safety and quality organisation, not from a public health or a communication organisation, and so this is a bit of a different take and probably a complementary perspective on health literacy and how we're starting to think about it and starting to tackle it in Australia. Just to give you a bit of background, the organisation I work for is the Australian Commission on Safety and Quality in Healthcare, which is a national leader around, national government-funded body, leads and coordinates safety and quality nationally. We have quite a broad remit across the whole health sector, public and private, acute and primary care settings. And we're quite a small organisation, we're about 40 people, so really the way we do our work is through consultation, collaboration, dialogue, discussion. Our main areas of work to date have been around national standards, and I'll talk a bit about that later, and accreditation. That's been something we've been doing since we were established. We have a large role around data and indicators, development of data and indicators, particularly in the area of safety and quality. And then the processes about reporting and publishing and about knowledge and leadership, that kind of role. So what I'd like to do firstly is really to describe how we are looking to build health literacy into our national approach around safety and quality. And the first part of that is Australian Safety and Quality Framework for Healthcare, which was something that the Commission developed in 2010, endorsed by health ministers in Australia. And it has three components, as you can see. The vision for safe and high quality care in Australia, that is consumer-centred, driven by information and organised for safety. And underneath that, there are a number of actions that have been identified for the health systems and a number of attributes of what that means for people, consumers and patients within the health system. And you can see the square that I've put around. This is only one part of the actions, only the ones to do with the consumer-centred angle. We have included health literacy in there. So how can we, making sure that people have information they can understand, be able to involve in their healthcare, improving safety in that way, and increasing health literacy as a part of that. Underneath the framework, it really sets out the overall vision for what safe and high quality care looks like in Australia. And underneath that is some work that we've done over the last 12 months or so, describing a set of safety and quality goals for healthcare. Now, what these goals are really trying to identify the specific areas of work. The framework sets out the vision, whereas what we're trying to do with the goals to say, okay, if we're going to be doing safety and quality work, what are the areas that we really should be working in? Where should we be focusing our efforts? What are the areas over the next 5 years or so that would be amenable to national action? And so we've gone through a large process to get to this point, and these goals have been endorsed by health ministers just last month. So there are three goals, high-level goals, one around safety of care that has underneath it a number of priority areas in the areas around medication safety, healthcare-associated infection, and recognising and responding to deteriorating patients in hospital. The second goal is about appropriateness of care, and underneath that, making sure that people receive appropriate evidence-based care, because we know that there is often a big gap between the evidence and the practice. And within that, there are two priority areas around stroke and around acute coronary syndrome as areas where there's burden on the system and good evidence. But the reason that I'm talking to you about this is actually the third goal, which is about partnering with consumers. And what this goal is talking about is that there are effective partnerships between patients, consumers, healthcare providers and organisations at all levels of healthcare provision, including planning and evaluation. And what we've done within that, we know that partnership is necessary for improvement in all areas of safety and quality, but really felt that it was so important and in such need of development, it needed to be raised to be the level of a goal in and of itself. Within each of these goals and the priority areas, we've identified a number of outcomes, a number of areas that we're suggesting we really want to see change over the 5 years. And these are the ones for the partnering with consumers goal, focusing here about chronic disease self-management, particularly so management of their own conditions, self-management, particularly for people with chronic diseases. The second one is about communication, so patient-provider communication. The first the third one really picking up on the work that's been done here at the IOM about attributes of a health literate organisation and see if we can move our organisations to becoming more health literate. And the final one being about involving consumers in a meaningful way in the governance of health organisations. So really covering the spectrum from partnerships that exist within when people are receiving care between the patient and their provider, but also partnerships that can exist at an organisational level and everywhere in between. So it's quite an ambitious goal. I don't know how far we'll get in 5 years, but nonetheless we felt that we needed to identify these things. And what we've done then also is, within each one of those outcomes, is to develop what we're calling action guides and trying to identify what are the actions that need to be taken across the whole health system. So if we're in 5 years' time, we're looking at this and we're saying, where would we want to be? What would we be saying, this is great that we've achieved this? What would success look like? How will we know when we get there? Very difficult in this area because there's the measures and the sort of thinking about evaluation needs more work. But then what are the actions that can be taken, not just within by governments and within the health system, but actions that be taken by patients and carers, actions that can be taken by providers, by health services, hospitals, and the Commission as well. We've also, I couldn't fit, it's already crammed in, there are people that I couldn't fit on that slide in terms of research organisations, universities, training organisations, non-government organisations. So we've tried to identify actions that can be taken across the board around achieving these goals. So the final, going the wrong way. The final part, and probably at the moment one of the most important parts of this sort of national approach to safety and quality that we're looking at how we can build health literacy into, is some work that's going on about national safety and quality standards. So that logo stands for National Safety and Quality Health Service Standards. Way too many letters all over the place here, but that's what that one stands for. So accreditation and accreditation reform has been a core part of our work since the Commission was established in 2006. And there are really two parts to this work. The first is the development of this set of safety and quality standards. And the second part is our role as coordinating accreditation nationally. Accreditation is something that's been going on in Australia for a long time. Most hospitals are accredited, but there has never been a consistent set of safety and quality standards that has been mandatory across the board for all hospitals and day procedure services, which is what's going to be happening now from the beginning of next year. And so what we're really trying to do with these standards is to move away from a perception of accreditation as a tick box checklist process to really thinking about using these standards as the basis for quality improvement. So an ongoing cycle of quality improvement where the standards provide the focus for action. We haven't included health literacy as such within these standards, and the standards themselves cover a whole range of different areas. There are two standards that overarching standards across the board, one about governance for safety and quality and one about partnering with consumers. And then the other 8 standards cover what you would expect from a sort of patient safety perspective in terms of things like healthcare associated infection, medication safety, clinical handover or handoff, patient identification, use of blood and blood products, pressure ulcers, falls and deteriorating patient. So we haven't explicitly included health literacy in there, but nonetheless it is there throughout. There are items throughout all of the standards that pick up on issues to do with health literacy. So you can see some examples. These are not all of the examples, but a few of the examples up here. So the first one comes from the governance standard, and it's really focused on that partnership that happens between a patient and a provider when they're receiving care, and so making sure there are processes in place that enable people to be part of that decision-making process. There are a number of items around information for consumers, around consulting people around the type of information and how it's developed. And within, so 2.4 and 2.5 are from the Partnering with Consumers standard, and then 4.15, and there are similar ones in all of the other ones, about providing information in a way that can be understood, and in a format that can be understood. Now, it's not ideal, it's not the best that it could be, but it's a starting point, and these things are going to be mandatory, and it will be very interesting to see how hospitals go in terms of meeting these criteria within the standards. So this is a framework for the national policy framework, and I wish I could say that I knew how that was going to go and that it was all in place and all happening, but that's not the case at all. A lot of this stuff is really quite high level, and we haven't got there yet, and we haven't yet started. People are putting the standards in place, but we really haven't worked through the process of how that's going to be. I do have some information about things that are happening, and it's interesting how Canada and Australia in so many ways are doing similar things. So we've done over the last 6 months, really earlier this year, what we called a stocktake, a national health literacy stocktake. It was not a systematic process, it was not a comprehensive process, and some of the information in it informed Andrew's paper, which was a great opportunity that we were able to do that. So I just wanted to give you a bit of a quick view that we weren't actually able to put in because we hadn't done it yet when Andrew was collecting his information. So this was between December and March this year, and we put out an invitation quite widely. We didn't have the capacity or the resources to go out and actually comprehensively collect information, so it really depended on what people gave to us. We had 66 submissions describing over 200 different initiatives, and we really found a whole lot of stuff going on, a whole lot of different organisations doing a whole lot of different things, and a range of different approaches that were being taken. And I'll just talk briefly about that in a second. But I guess one of the overarching things, and similar to what Sandra was saying, things are quite fragmented, and there's pockets of bits and pieces going on in various places, but really few opportunities for learning and sharing of information. And certainly whenever we've talked about health literacy, the response has been very positive. People have wanted some national coordination, and hopefully we're going to be able to do that. So just quickly, this is the results of what we found with the different types of initiatives. That we had initially thought that we might be able to classify these according to, whether it was about print literacy or whether it was about, critical literacy or some kind of the theoretical frameworks, and that was not the case. What we really found was these are the type of work that people are doing to improve health literacy. And you can see here, I'll give you some brief examples. So in terms of the policy and framework stuff, this was sort of, for example, a state government that had a policy, one of the few state governments in Australia that actually had a health literacy policy. Most of the information we received was about health information, so where people had developed things, resources about topics that they had either worked with the target group or experts on. So, for example, things like fact sheets for people with disabilities, things like radio campaigns for different ethnic groups. That was the most common by far. There were a number of projects that were looking at improvement of skills. So there was a project around working with people who had a chronic illness to develop up their self-management capacities. That kind of thing went into the green one about improvement of health literacy skills. People were starting to look at projects that were looking at the environment. So what the health literacy environment was, for example, in a hospital. There were only a few projects. There were some projects were doing workforce training, so training, building capacity, understanding about health literacy. And then there are quite a lot of researchers in Australia about health literacy, and received quite a bit of information about work they were doing in terms of things like measurement of health literacy, evaluation of decision support tools, effectiveness of information resources were the kinds of things that were going on here. So that was, and it's very useful information and sort of information that we didn't have before. I guess where to next for us, where I feel like we've been talking about health literacy for a while, and we now need to start to really bring it together. So it will continue, I think, the focus on health literacy as a fundamental part of safety and quality is only going to increase. In the 5 years I've been working at the Safety and Quality Commission, it has increased enormously, and there's really quite a momentum around there. The standards, the safety and quality standards, are going to be a huge driver in Australia over the next couple of years, and we need to look at how we can build health literacy into that. We really want to start work now, and for me, it's a great opportunity to be here and listen. We want to start to work on a national approach, and certainly Cynthia's discussion about the National Action Plan, I think, is something where we would like to head. We particularly want to focus on the aspect of what can the health services do, how can we reduce the barriers around health literacy as our main area of focus would be more likely than the more public health approach that some other people here might be taking. So that my email, our website, we've got information on there if anybody wants to follow it up, and thank you very much.
So, good morning. My name is Frederia Gazzotti. I come from the local health trust of Reggio Emilia, which is in Italy. I'm the director of the communication department. It's an honor for me to be here, and I really thank the Institute of Medicine and the National Academy of Science. So I have to understand how to change. Here we are. Where are we? We are in Emilia-Romagna region in Italy. It is in the north of Italy. It is the land where we produce Parma ham, Parmesan cheese, Ferrari cars. But nevertheless, we are facing, as in the rest of Italy, a severe economic crisis. And the government is implementing a spending review to reduce the public expenditure. This is the regional declination of the national health system. So this is our regional health system. In Italy, the region and the nation, the government, guarantees all citizens with universal and equal access to the services, and it ensures health care by means of local health trust, university hospitals, and universities and hospitals. Now we see some demographics we are facing, and it's quite a new phenomenon for Italy, not like in the USA. We are experiencing a strong migration, mainly from Morocco, Albania, People's Republic of China, India, Romania. And these new citizens count for the 13% of the total population. And the elderly, the over 65s, count for the 22.3. And as we will see in a minute, the literacy scale of adult population in Italy are very, very low. I made a mistake. As the updates of the whole study of the 2008 show, Italy is in the last places. Concerning health literacy skills. In Italy, one of the reasons may be that in Italy, half of the adult population leaves school only with a middle school leaving certificates. And once you leave school in Italy, it's very difficult to go back to school again. It's very difficult, it's very hard, and it's very, very difficult for adult population. We don't have many schools for adults who left school when they were young. We understood the importance of health literacy actually when we met Professor Rudd. We met her in 2007 in the US, and then we invited her to Italy, and we knew each other, and then we asked her to come to work with us. And she came, she accepted our invitation, so she came for a full work week in November 2011, then again in January, February 2012. What did we do? In 2008, we organized, in the company where I work, in the public company where I work, we organized a group on health literacy techniques, and then in 2011 we asked the region, we proposed to the region to form a regional group focused on health literacy and defining which activities were needed. You know, every local health company and every hospital leads to have to answer to the region. The regional group has 11 members. They are the 11 communication directors of the local health trust and companies and hospital companies. And then are members of the group also the training manager and the communication manager of the regional health system. The main objective of this group concerns the improvement of written and oral communication skills. To achieve these objectives, we use as I said before, we use the cooperation of Professor Rimarat, who came to Italy. This training course included 74 participants, which means 4 people from each local health trust. We had 2 groups, one composed of doctors and nurses working in oncologic sector. The other group was made by communicators, 1 communicator and 1 operator of front office. And on each day, space was dedicated to group work and analysis. And it was a very challenging and a very nice path. What did we do with the doctors and nurses? With them, we special attention was paid to the imbalance between the expectation of the system and the skills of the patients. And possible actions and methods were also proposed for improving patient interaction, including teach back. For the communicator, special attention was paid to the clarity of the language used in the information material. And also in this case, techniques were analyzed for reviewing, for creating, reviewing, and assessing the information materials. And then between the 2 editions of the training courses, Rima gave us homework, which we did. The clinician had mainly to try teach back in their words, and they did. And the communicators had to review materials and to find the barriers of the environment in their everyday activity. From, maybe it's the same in the States. If we have a training course, then at the end we have evaluation and learning a questionnaire, and from this questionnaire it emerged that even after a few days, of course, it was possible to achieve tangible results. And the participants remarked the need for a broader training. Some of them said this training should be mandatory for all the workers of the hospitals because they understood the importance of health literacy. And they also stressed the importance of the commitment of the regional level. After the training course, the 2 weeks training course, it was decided to implement 2 parallel paths on each local health trust. One is dedicated to the health professional-patient relationship, and the other to assess the information materials. And both paths are going to be carried out in 3 sectors, in 3 oncologic sectors: breast, prostate, and colorectal cancer. What are we going with the path which concerns doctor and patient's relationship? The dissemination of health literacy skills will be done by nurses and doctors who took part to the course held by Professor Rudd, and they will train other colleagues using a peer training method. So we will have repeated edition because the aim is to train all the workers, the health workers working in this three oncological sector. It will be a long work because there are many. Concerning the communication, this path, in each health trust, the information materials available for each oncologic sector will be analyzed, first at the local level with the patients, association, relatives, and then in a second time at the regional level, in order to achieve benchmarking and to create a regional template which could be customized by the region. Timing, maybe we will not be able to respect these deadlines, but we're trying to. By the end of 11-12, each local health trust should hold a two-day training course for clinicians working in the oncological field, as I said before, using the peer training method. And also the materials assessment and review should be ended by the end of 2011. I don't know if we will be able to, but we're trying. And the Regional Health Assessorate is working to become a health literature organization, and to achieve this objective, the assessorate included the development of health literature attributes amongst the main 2011-2012 goals for health trust directors. You know, each year the regional level assigns objectives that the directors must achieve. So this is one. The development of health literacy skills is given by the regional assessorate to our directors. That's it. Thank you for your attention.
Hi there. I'm sure everybody is dying for lunch, and just to let you know, I won't be going into too much detail today because we've just published a paper in Ireland which summarises the history of health literacy. So detail you'll find on the website. Just to introduce myself, my name is Jennifer Lynch and I work for the National Adult Literacy Agency in Ireland. And I suppose what I hope to do today is just describe the story of health literacy, talk about what has happened up to now, future developments, what needs to happen, and new opportunities in Ireland. Just to explain, Ireland has a population of 4.5 million. We're in the middle of a baby boom right now. We have the highest birth rate in the EU. We also have an ageing population. And we actually have a diverse population, which is really a recent event. We have 12% of immigrants people have come to Ireland from Poland, Lithuania, Sri Lanka, the Philippines, to work or study. And that has implications also for health policies. And I think some people working with the public have also found that very challenging. So, NALA stands for National Adult Literacy Agency, and it was established 30 years ago. It's unique in that it's a non-profit voluntary organisation. We get a core grant from the Department of Education, but we are independent. And that means that we're free to engage in lobbying work, which is really, really important. Now, the agency also relies on extra funding from different agencies as well to develop projects. And I suppose in recent years that money has been cut consistently with the recession. So, for example, we have projects in workplace literacy. We also have projects in family literacy programs, and some of them are under threat just with the recession. And we have a budget coming up in December, and we have been warned that it's going to be a very harsh budget. 70% of the education budget in Ireland and the health budget goes on staff, and we have national pay agreements. So really the ministers have explained to us that they can only play around with 30% of the budget. So we have been warned that there might be another cut on the way. So just to explain, I'm just going to give you this image here, which was designed by a colleague of mine. And it just explains the kind of work that NAL is engaged in. And I suppose since the results of the International Literacy Survey, NALA has tried to make adult literacy relevant for people working in areas outside the educational issue, because of course it's a civic issue. And I think that's a very good image of the kind of work that we're engaged in. Our definition of adult literacy as well is quite broad. For example, we talk about literacy involves listening and speaking, numeracy and using everyday technology. But we also talk about the fact that it includes more than the technical skills of communication. It has personal, social and economic dimensions. Adult literacy learners are represented on our national committee, and they're actually represented in all our committees, in all our projects as well. So, it keeps us grounded. So if I just go back there. And just to explain, in Ireland, we have 55,000 Irish adults attending their local VEC, and the local VEC would be the main group body responsible for providing adult literacy tuition. It's a new profession in Ireland, adult literacy tutors. It's a professional profession, but there is also a reliance on volunteers for one-to-one tutor. So if you're a member of the public and if you want to improve your literacy skills, you contact your local VEC, you will be assessed, and then you usually start off on a one-to-one basis with a tutor. And when appropriate, then you will be encouraged to move into a small group. And also in Ireland, we can now offer accreditation for people with relatively weak literacy skills. So that's a very big development. Okay. Now, I know that the actual results here look quite old, because I'm referring to 1997, and we will have refreshed adult literacy results next year with the PIAC. But for the minute, like the government, we still quote the 1997 adult literacy survey results. I'm sure people in this room who are familiar with adult literacy were very familiar with this survey. It was based on a 5-level sliding scale, with level 5 representing very good functional literacy skills, and level 3 was considered the norm to cope in societies. And 25% of the Irish population scored at level 1, which meant that they were struggling with everyday materials. And one of the everyday materials that they used in this survey was actually a packet of aspirin, where they asked people a question such as, how long can you take tablets? How many days can you take these tablets? And 23% of the Irish population could not answer that correctly. So that was actually very relevant for NALA, because we had been used to getting phone calls from people in the health service telling us that, they weren't too sure their clients were understanding instructions. And here we actually had the proof. So that was a very powerful example. And those results came out in 1997. But this really is the most important publication in Ireland when it comes to health literacy, because it was the first health paper that acknowledged health literacy and talked about literacy being a barrier to health promotion. So the agency contacted the Department of Health, and we sat down and we actually came up with a strategy. And I suppose just to go back there a second, with this strategy, this is the actual definition that we've always worked with. Adult literacy learners really like this definition, as do literacy tutors. It's very balanced. I think it's very straightforward. And I know other definitions have been produced in the meantime, but it's still the most popular one among our clients. Okay. So we go back to our strategy, which was produced in 2002 and launched by Rima Rudd, who travelled to Ireland. And we were very grateful to have Rima there discussing our strategy, and it was very, very exciting. And to be fair, the health promotion unit really have been the driving force when it comes to health literacy in Ireland. I suppose it makes sense in a way because health promotion practitioners work on the ground, so to speak. They work in education, so it's a good match that they would liaise with adult literacy practitioners. I have here the role of plain English because it actually, plain English, we find, has actually been a very important ingredient. The agency has very much developed its skills when it comes to plain English, and I think is seen as a very credible agency when it comes to editing materials and making them literacy friendly. And we've actually trained 300 communication staff. That would be people largely working in the health sector and for the government. And plain English service is used very much for national strategies. I'm thinking of one which is the breast check, which is a national breast screening programme. And I always cite it because it's a very good example of an initiative who embraces health literacy and literacy from the onset. And they have done great work. Their staff are literacy friendly, their material has been literacy proofed, and they use focus groups continually to improve their service. So plain English has been a very powerful tool for the agency. The other thing, we produce teaching materials, all very necessary, produced by health promotion people and literacy staff. Used on the ground, and very important when you're trying to integrate health into a literacy programme. And then, inspired again by Rima Rudd's work with Jenny Anderson, we produced a health literacy tool. And I think this document has been very important for NALA when we're trying to get into clinical settings, because you know, we have embraced, we've been embraced by the health promotion profession, but it's a bit hard when you're trying to get into other areas. And this publication, what it does for us really is it translates health literacy into practicalities, because it asks people to analyse their own setting and their own procedures. So we use that in different clinical settings when we're invited. In 2007, we were approached by Merck Sharp and Dome, who were interested in developing health literacy in Ireland, and that's proved to be a very interesting collaboration. For example, we have developed a health literacy website, which is super. More importantly, every year we have what's called Crystal Clear Awards, and that's where health practitioners on the ground in different categories tell us about the kind of work they're doing and how they're making efforts to make their material and their practices literacy friendly. And that's really super for the agency, because it means that we have access to, you know, a wide variety of health practitioners, and I think it's good as well to reward people doing their best on the ground, trying to make a difference. Okay, 5 minutes. Okay, so that's just basically a summary of what our health strategy has been. We've all had a bit more energy in the last 2 years, thanks to work Christine Sorensen will be talking about later on, the European Health Literacy Survey. When Rima Rudd was last over in Ireland in 2009, we introduced her to our Minister for Health at the time, Mary Harley, and we got money from the National Lottery so that Ireland could take part in the European Health Literacy Survey. And there are the results. Basically 40% the Irish public have weak literacy skills. And we didn't do too well either at the very end. 21% of respondents had excellent. Okay. So the good thing about that project is that Merck Sharp and Dome actually gave money to NALA to organise a number of roadshows where we actually publicised the findings and also engaged in plain English training.
Okay, so just in terms of what needs to happen, we are very grateful to the American research and Canadian research, but really we do need Irish research just to come up with Irish solutions. We need health literacy integrated into all national health campaigns automatically. That is happening at the minute, but it needs to continue. I also have here that we need to integrate health literacy into training at undergrad level. I think that will happen when we have more Irish research. I just wanted to show you one statistic here. This is based on, again, Merck Sharp and Dome sponsored questionnaire among medical doctors in the community. And the results were fairly depressing, I think, really, because I do hear from practitioners that, yeah, we've done communication research, yeah, we've done communication training at undergrad, and yet the finding that the one in the middle here was particularly perplexing. Nearly 40% had not received training associated with patient communication skills. Okay, so that just shows that the role. The other thing is, in Ireland, health literacy isn't part of our Irish healthcare accreditation, and ideally we'd love to see that happen. Again, rewarding good practice, a national awareness campaign among the public. You know, I think there's a role as well for the public to start demanding a better communication. Okay. So I was thinking of, in Ireland, I was thinking of Don Nutbeam's paper on developing health policy recently when I was writing this, because timing is everything. And our health promotion strategy has finished at this stage, so really we're looking for a new one, and I think that might come. The public health strategy, the third one down there, will be launched in the next few months, and we are really hoping that health literacy will be mentioned there, because that really is a refreshed health promotion policy. The cardiovascular strategy, which was published last year, did actually cite health literacy, which is interesting. So again, NALA would be campaigning for action to come from there. And I have professional competency there because only last year general practitioners in the community engaged in a professional competency programme, and they were able to integrate health literacy into their audit. So that's a new development. Okay, listen, thank you very much for your time. Thank you.
Thank you very much. And now we have an opportunity for questions and comments for this panel. And once again, I'd like to invite people to come to the microphones. I'd like to invite people to identify themselves and their organizations and ask their questions. And if you could come to the microphones as others are making their comments, that would help us move along. Bernard?
Bernard Dreyer. I'm a member of the Roundtable and a pediatrician here in New York. I appreciated all your presentations, and it was interesting and edifying to hear about the efforts in all of your countries. My question is, I heard a number of themes, and we've been talking today about sort of where to begin and how to move this into action. And where do you think the first step from your experiences so far should be? Should it be in healthcare organizations? Should it be in the public health arena? Interestingly, should it be at a focus on some broad area of disease or prevention that would give us most bang for our buck? Because I think one of the issues for all of us is, where do we start in trying to move the needle towards real health literate healthcare?
So comments from the panel on the staging of how one progresses through national competency. Please.
I can't answer that question completely because I don't have full knowledge. I feel a little bit of a fraud here because I'm not a health literacy expert, but I can give you my perspective. I think we, as an organisation in Australia, we've had trouble working out where we can start with health literacy because the issue had always seemed such a huge problem, and while we recognise that it was an important aspect of safe and high quality care, where could we actually get in and do something? And for us, it's only really been since turning around and not thinking about it as a public health issue or a health promotion issue, but thinking about it as an issue where actually health services can take some action, that we've been able to think, okay, yes, this is how we can move forward. So I don't know that there is one answer to that question. I think the answer may well depend on what you're trying to do and who it is that's trying to do it. So that's a case from my perspective. There's been a lot of work going on in Australia around health literacy for a while from different perspectives, and some of that's been successful and some of it hasn't. I guess from my perspective as well, I think trying to raise it up to have a national profile is also going to be really important, and it has been quite a successful strategy in other areas of our work to really give things a bit more impetus. So from that perspective, that's where we're going to be starting.
Other comments from the panel?
I don't have an answer. The regional group had to decide between chronic disease, diabetes or so, and cancer path. We started from cancer path because we thought it was a very particular area. This is only, I mean, one of the reasons, but the aim is to extend this training to other sectors, also to public health, of course.
I think you need to find out as well who is ready for health literacy. So I think timing is very important, and what we have found is it's easier for new strategies, new programs to embrace health literacy from the start. It's always so much harder to go back and try and retrofit it. So the other advice I'd give is to really start reading policy papers and action papers, which is kind of work that I'm engaged in, looking at health initiatives, and especially when you have a new government as well. You know, we have a new government in Ireland. It just came in 2 years ago, so they're obviously busy producing their own policy papers and health strategies. So it's really trying to make your work current, and you do that by actually putting in the work now that they're reading.
Sandra?
I mentioned the intersectoral approach, which is a positive step in the right direction, which brings it, the presence and the profile to a higher level. But there's, as I mentioned also, there's pockets of health literacy work happening all over the country, and the nexus of activity is happening in BC, and I think a reason for that is there's a lot of keen interest and momentum happening, and largely in part because there's a BC Health Literacy Network, which is really a network of networks, and that deals with a lot of cross-sectoral of work. So they have a mental health network and a library network and a seniors network. And so I think that really does give momentum and infrastructure. And just as an example, within that, they have within the mental health literacy network, they have a health literacy director, so they have a position, they have funding, they have a provincial mandate and strategy for mental health literacy work. So that's just one example, and that's a unique model in Canada, the only one right now. And if they have that type of model or network set up, and with this new blueprint for action, I think that will really be a catalyst to also get the ball rolling.
Just listening to the presentations, I see that it's important that that the concept be defined, and in a way that's appropriate to the local country, the local population, culture, that awareness be built, that there are interesting attempts to survey both internationally and within the country. But there's a very common need to take the surveys and learn from that as an individual country, what can be taken from that and used locally. I noticed that 3 of the countries talked about attributes of either organizations or others in defining those. I know we've recently worked on attributes at the Institute of Medicine of health literate organizations. Be interesting to learn from each other on that. I'm very interested in the economic constraints that were mentioned by 2 of the presentations, which make Bernard's question quite poignant. And the role of experts. We heard Professor Rudd and Professor Nutbeam mentioned in terms of making presentations, making expertise available, and then progressing to areas that relate to standards, actions, activities, and so forth. As I've said before, I'm no expert in health literacy, but certainly in healthcare delivery and quality. Taking a concept and personalizing it, and then making it actionable through these steps seems to have some general application. So that's my own editorial comment on this very important question. Back to you then.
Hi, I'm Susan Pisano, and I'm a member of the Roundtable, and I work with the health insurance industry here. And I can tell you that what we've been hearing today will be of great help to our own work, so I really appreciate what you all have said. I think that all four of you mentioned your immigrant populations. And one of the challenges for us here is diversity and making sure that we're paying attention to the cultural differences among our people. And so I'm wondering if you have anything to say about how you do that in your countries.
So the adaptation to the migrant populations and addressing the cultural diversity and challenges that come with applying health literacy principles in these populations. Was that your question? Go ahead.
Well, I just briefly touched upon it, but the one example was the Learning for Health or the Embedded Learning Project, and one of the demonstration sites was an immigrant site dealing with immigrant health, and I know that they had ESL site champions and with some of their tools. So that was one of the sites that was chosen specifically. And so increasing the knowledge and skills of the workers and community groups, and English as a second language was something that they focused on within that particular site. And I know with the Family Resource Center, I know that they focused on cultural competency there as well. So just briefly, that was something that they were working on, that large project.
Well, in my region, as I told you, we have a strong migration, and we developed a sophisticated system of mediators in every hospitals and in the primary care. Everywhere we have mediators. So as a paradox, the use of mediators is much more near the needs of immigrants. I mean, a mediator normally speaks in a way that the immigrant can understand. We have a biggest problem with Italian people. I don't know if I got the idea. The mediator use everyday language, translate materials in everyday language. So Italian language, on the contrary, is quite difficult, a complicated language. So we decided to start with oncological path, but no matter what the country of provenience of the people is.
Thank you. We'll go to the back then, and then to the front.
Wilma Alvarado-Little. I'm also a member of the Roundtable, and I'm from the Center for the Elimination of Minority Health Disparities. My question is very similar to Susan, so I apologize for the redundancy. We should have coordinated our questions. But my question is regarding the use of the language access component in the dissemination of information to your very diverse populations. Is there a funding source in your countries regarding the translation of documents that might be useful here? In upstate New York, we have a large refugee community, Karen, Somali Bantu, and so our resources are very limited. I'm just wondering if there's other strategies that you have utilized to address some of these other issues.
In Australia, there isn't a separate funding source for that, and certainly I know that some of the health services in some of the outer metropolitan areas of some of the big cities like Sydney and Melbourne, who have large immigrant populations, do struggle sometimes in terms of that. I don't quite, I don't know what the answer is. We certainly don't have an answer, unfortunately.
Are there further comments?
Yeah. I know in Ireland there was a fund, a translation fund that health providers could avail of, and I know, for example, when national information leaflets were produced, they were produced in a variety of languages, but that work has really dried up in the last few years, and I think as a result organisations themselves from different minorities are kind of doing work on the ground, trying to help their colleagues because of that budget having dried up. It just wasn't sustainable.
Cynthia, and then to the back. Cynthia?
Cynthia Bauer, Centers for Disease Control in the U.S. So I wanted to actually turn Bernard's question around the other way, because I've presented the U.S. action plan in 3 different international contexts. And the most interesting conversations are actually talking about the cultural specificity of natural planning. And the most recent episode was when I was in Canada earlier this year, and even finding out that the idea and the word national had cultural specificity. Could you even talk about something that was national in a context? So I actually would kind of think about the question a little bit differently, is sort of if you could come up with one thing that you think is very culturally specific that you need to address in your health literacy planning, is there a single issue that you could identify that says there's something specifically Irish about health literacy in your approach and something specifically Italian? Because I think it's that cultural specificity that makes this kind of interesting too.
All right, interesting challenge to the panel.
We have 10 minutes to think about it.
Lunch. And I think it's a good point, because I think national does mean different things, and I think in Australia, having had conversations with Rima about the Australian health system and the American health system, it's a different thing, and I know that the way that it's not necessarily even a cultural thing, a political thing about the way countries operate and the way that health operates. I know the first time I came to the States for a health conference, I was blown away by the complexity of your health system and the number of players all doing different things, and I just don't know how anybody keeps track of it. I thought ours was complicated. And so it is certainly an important thing to think about. Well, what does national mean in our context? I think we're in a good position in that our organisation has, over the last 6 years, done national work that has been agreed by all of the states and territories. So in Australia, the bulk of public hospital services are delivered by the states. We also have a very large private sector. We also have a somewhat fragmented primary care sector. And so most of our work we've been able to achieve success, particularly with the states around public hospitals and around the private hospitals. And I think we'll be able to do that with the health literacy area. The difficulty, and both the difficulty and the really important part, because of the large proportion of the population that receives care only in primary care, is going to be in that sector, and that's the difficulty, because it's so much more fragmented, so much more difficult to work out where to go in and to try and get agreement. So I don't think that answers your question, but that's sort of my perspective on how national work what it might mean in this space.
Any other takers on that question? Tough question. Okay, we're gonna think about that one for a while. Please.
Hi, Thomas Sang from Merck Pharmaceutical. Until recently, I was actually involved with the development of quality measures in the federal enterprise. And as you know, we're at least in the U.S. market, we're shifting from a fee-for-service environment to a much more holistic payment policy, and we're going through a lot of delivery and payment reforms. Some of the newer payment policies are looking at value-based purchasing and quality measurement of the way we deliver care. And we're trying to, at least when I was still in the federal government, we were thinking about measures that would actually assess patient engagement and shared decision-making. So I'm wondering if you are using measures to evaluate provider engagement of patients in your countries, and what type of clinical quality measures are you using for payment policies?
No, in Italy we don't. We don't yet. We don't have any method. We haven't developed yet any method for measuring. So
in case the people on the web did not hear that, your response was not quite yet, not from Italy.
Yeah, I'm not aware. I'm not sure.
We're starting to talk about it. We don't have as yet. One of the recent health reforms in Australia has been the establishment of a new pricing model around public hospital services, the national efficient price, and initially it was conceived that that would include some measures around safety and quality and even potentially about patient experience. Neither of those things have happened in the initial draft of the efficient price, so that's something to keep on the agenda. It hasn't occurred yet. We do have some agreed national indicators around safety and quality and are doing work around patient experience. Haven't yet got as far as sort of this kind of angle around health literacy, but it's something that we would like to certainly work towards.
Go ahead, Jennifer. No?
Don't have any yet.
Okay. So those of you, just to build on that question, those of you who mentioned accreditation, do you anticipate measurement as part of accreditation, or how are you thinking about accreditation in the context of the recent last question?
Yeah. Well, our accreditation system is actually quite new, and I think they've veered away from the actual ticking boxes, and we actually do engage with HICWA, so I think it's kind of a good opportunity for NALA to engage down the line to come up with a credible way of measuring communication.
Mm-hmm.
Yeah. I mean, with our standards at this point, it is going to be whether for each of the items a health service that's met or not met. So it is a met, not met, and then met with merit, however that might be defined. So it is a fairly black and white thing at this point with that, and doesn't really go down into the detail of what that communication might look like. Again, I think it's something that we would like to do some work on, and having this conversation is a starting point for that.
Thank you. Andrew.
Thanks. I'm Andrew Pleasant, also a member of the Roundtable. I'd just like to ask each of you, as well as our afternoon speakers, Don, you know, we're all here trying to learn from each other. That's the goal, and it's fantastic. But I'd like to hear what you think we could do from this point forward, after today is over, to keep that discussion going internationally. How can we share best practices, yet still allow the localization of those to fit the culture that we're in? What would such an effort or organization look like? Thanks.
Thank you, Andrew, for that question.
We get the hard questions. What's going on here?
There's no question worth answering if it isn't difficult.
No, I didn't have anything to say.
Well, I know I was talking to Andrew earlier on about the fact that, you know, we would talk about the use of teach back and different communication techniques, you know, and I tend to quote the one or two studies that are out there who have evaluated it, and I was saying it's like research evaluating outcomes and techniques such as that are really, really powerful when you're sitting down across the table from somebody and talking about literacy and then health literacy, you know, because they want to know what's in it for me, how long is it going to take, why should I change my practice, because ultimately that's what you're asking people to do. You're asking them to do something else on top of their work now, that they're being paid less for now. So, you know, I suppose I'd love coming away today if I kind of felt more assured that people were going to assess what they're doing.
Other comments? Okay. And this will be the last question from that demo.
My name is Christina Sørensen. I'm from Maastricht University and coordinated the European Health Literacy Survey. And maybe I can answer some of the hard questions. Coordinating the European Health Literacy Survey, we were working together with institutes from 9 countries and a lot of other partners from Europe and globally. And basically we had some of the barriers being how to translate literacy. So the discussion we had earlier on cultural sensitivity starts with the word literacy. The solution has been that in many of the European languages it's translated into health competences. We have to agree that sometimes The words seem different, but it means the same. So we have to take into account the context and content-related approach in health literacy. And the question from our colleague Andrew Pleasant in terms of how to continue the discussions. I think this meeting is really a first step to have a dialogue across the Atlantic and globally. And we've launched a little survey with a colleague from UK to see what could be an international platform and what's the interest for having an international platform on health literacy. And I'm happy to distribute it to this audience as well and have your input to it and discuss it for further consideration. Thank you.
Thank you so much for helping the panel with that question. It was a great question for all of us. And as we go on, if those of you in the audience want to offer answers for some of the questions previously offered, that's quite fair. Again, the rules of engagement here for a roundtable workshop is that if we don't talk about it during the workshop, it doesn't make the report. So we won't put the entire burden on you. But I think we ought to give this panel an extreme, entire amount of credit. Thank you so much.